Hello and welcome to your video lecture on Chapter 35 on alterations of pulmonary function. The first thing we're going to discuss are the signs and the symptoms of pulmonary disease. Now, most of you by now have already heard of the term dyspnea, and this is described as more of like a breathlessness. You feel like you're air hungry. Also, it's known as shortness of breath, but when you're having labored breathing or just almost like a preoccupation with breathing, it's falling under this umbrella of dyspnea. It may be because you have a pulmonary disease, or it could be some other conditions such as pain, heart disease, trauma, and anxiety. For instance, about 2 years ago, I had this crazy amount of pain in my left ankle. I just felt like somebody took my fibula and snapped it in half, and I felt like I could not breathe because the pain was so unbearable. And then so under this umbrella term too, we are going to have orthopnea. And this is when someone is having difficulty breathing when they are laying down. It just causes the abdominal contents to be pushed against the diaphragm, and with that pressure it makes it a little bit more difficult to breathe. And then we have paroxysmal nocturnal dyspnea, or PND, and this is when individuals with a pulmonary or cardiac disease are going to awaken up at night gasping for air, and they have to sit or stand up in order to relieve that dyspnea. Another symptom of pulmonary disease is going to be to have a cough, which is going to be a protective reflex that helps clear our airways by an explosive expiration. And we could classify this as being acute, meaning that it's going to last about 2 to 3 weeks, or chronic, meaning it's persistent and going much longer than that. So with our acute cough, it's most commonly going to be a result of an upper respiratory tract infection. It could also be allergic rhinitis, acute bronchitis, or pneumonia. Some other diseases that may cause this to come about is congestive heart failure, pulmonary embolus, or aspiration. And if it is chronic, it's most commonly triggered by postnasal drainage, which can happen, after you have a cold or have allergies. It can also be due to asthma, bronchitis, and could be a side effect of using ACE inhibitors, or angiotensin converting enzyme inhibitors, and also gastroesophageal reflux disease, or there may be no identifiable cause. Sometimes people just have this cough that comes and it tends to appear at the same time every year, and then it just goes away. We do see that with a chronic cough, it does appear in more of the people that smoke and have chronic bronchitis. These are going to be the most common causes of getting a chronic cough, although lung cancer always has to be considered as well. We should also keep an eye out for any abnormal sputum. Sputum is really going to be a mix of the saliva and the mucus that's produced in the respiratory tract. So we're looking for things like changes in color, consistency, maybe the volume of sputum, and also the composition, because we might see some things that can suggest infection, inflammation, or other types of pulmonary conditions. We really want it to be more of a clear or white if it's normal, and if it's any other color like yellow or green, a rust color, pink and frothy, or red, then we're going to want to investigate, right? So especially if we see that it's a little bit red, it may be hemoptysis, which is when we are coughing up blood or like those bloody secretions, and that can indicate things like tuberculosis, lung cancer, pulmonary embolism, or severe bronchitis. If that blood also is a little bit more dark, then it has a acidic pH, and it's typically mixed with food particles. If we see that it is bright red, that typically means it is more alkaline in pH and could be mixed with a frothy type of sputum. So that frothiness could suggest pulmonary edema, especially linked to heart failure, especially if it has a little pink to it as well. Now, we've talked about abnormal breathing patterns a bit in a previous lecture, but let's just revisit breathing in itself. Our ventilatory rate can range from 8 to 16 breaths per minute, and our tidal volume normally will range from 400 to 800 milliliters. And we know that our patterns of breathing are going to automatically adjust to minimize the work of our respiratory muscle. So it really kind of depends on what we're doing. But if we have labored breathing, that means that we're going to have to increase our work of breathing, especially if our airways are obstructed. Whereas if we were to say that we have restricted breathing, that is usually going to be a cause from a disorder such as pulmonary fibrosis, anything that really is going to stiffen our lungs or the chest wall and decrease compliance. And that will cause smaller tidal volumes. Remember, we said the normal is 400 to 800 milliliters. And also we will have a rapid ventilatory rate, which we call tachypnea. And then we are going to revisit our Cheyne-Stokes respirations. They're characterized by these alternating periods of deep and shallow breathing from, almost like an apnea. And this is really caused by any condition that reduces blood flow to the brainstem, which in turn is going to slow the impulses, sending information to the respiratory centers of our brainstem. And then we have our Kushmal respirations, which we also know as hypercapnia. And this typically happens when we have strenuous exercise, or again, another revisit of previous content, but it is an indication of metabolic acidosis. And some other terms that you may be familiar with is hypoventilation, where we have inadequate alveolar ventilation in relation to our metabolic demands. So it's taking place when our minute ventilation, which if you remember from our A&P course, we talked about minute ventilation. That is our respiratory rate times our tidal volume, and that minute ventilation becomes reduced. It's typically caused by alterations in our drive to breathe, so more of that neurological control, or our ability to respond to that drive, referring to our pulmonary mechanics. And so you can see within this condition, we are going to have hypercapnia take place, in which our carbon dioxide removal isn't able to keep up with our carbon dioxide production. And so our partial pressure of carbon dioxide is going to increase, causing this hypercapnia. And we then will have a fall in pH, which can lead to respiratory acidosis. And it's kind of difficult for us to detect this clinically, so we really do need a blood gas analysis so we could check those carbon dioxide levels or detect changes in the inspired and expired air. Then we have our hyperventilation, which is when our alveolar ventilation is going to exceed our metabolic demands. So our lungs are removing the carbon dioxide faster than we can produce it in in our cellular metabolism. And this could cause us to then have hypocapnia, where we will have a decrease in our partial pressure of carbon dioxide, and that results in an increase in pH and lead to respiratory alkalosis. And we see this in people that have severe anxiety, acute head injury, pain, and in response to conditions that are really going to affect our lung and chest wall. And in certain pulmonary conditions, we can have cyanosis, which is that bluish discoloration of our skin, which you could see pictured over here, and our mucous membranes, caused by increasing amounts of desaturated or reduced hemoglobin within our blood. So when we have peripheral cyanosis, which is our slow blood circulation in our fingers and toes, it's typically caused by poor circulation, which is resulting from heart disease, intense peripheral vasoconstriction, which we saw when we discussed Raynaud's disease, or cold environments. And we can really see this the best in the nail beds. So if you look at this picture over here, you can see that. And our central cyanosis is going to be caused by decreased atrial oxygenation, meaning we have low partial pressures of oxygen, from decreased inspired oxygen. So when we travel to areas of high altitudes, this may happen. It can also happen when we have central nervous system disorders that are going to affect our respiration, and pulmonary diseases, of course, cardiac diseases, and we tend to see its effects detected in our buccal mucous membranes and lips. Now, if some of this has been going on for a long time, we can have clubbing take place. So this is really associated with diseases in which we have chronic hypoxemia. And by hypoxemia, we're referring to having a low level of oxygen in the blood. And this can happen in conditions such as bronchiectasis, cystic fibrosis, pulmonary fibrosis, lung abscess, and congenital heart disease. And unfortunately, it's not really reversible. But we see this bulbous enlargement at the end of our digits. You could see the different levels here, and some people that have this, symptom going on. And the idea behind it is that platelet clumps escape filtration by the pulmonary bed and enter systemic circulation, and then we release a platelet-derived growth factor, which causes periosteal changes near the nail beds. So that's why it kind of extends all the way to this area here. And then, of course, we can have pain take place, especially if it's affecting our pleurae, the airways, or the chest wall. In A&P, we talked about pleurisy, and that can happen when we have an infection or inflammation of our pleura. And this is also sometimes referred to as pleuritis, and this can cause a sharp or stabbing pain where the pleura stretches during inspiration. And this is then going to create a friction rub that can be heard over that painful area. We can also have pain if somebody has high blood pressure in their pulmonary circulation, and that is known as pulmonary hypertension. And if you've ever been so sick that you have excessive coughing, it may make your muscles sore and even lead to a rib fracture. I know I myself, about 2 years ago, had the flu twice within 1 month, and I was just coughing so much I swore I fractured a rib. It turned out to just be a bruised rib, but it hurt a lot. All right, let's move into hypercapnia and talk about that a little bit more. So we said it means when we have a higher partial pressure of carbon dioxide, typically caused by hypoventilation, and these high levels of arterial carbon dioxide can cause cerebral vasodilation. And that can result in what we call somnolence, or can even lead to a coma. And somnolence is really a state of drowsiness or a strong desire to fall asleep. And this is because in this condition, we're limiting the amount of oxygen available for diffusion into the blood, and this can lead to a secondary hypoxemia. Now, within this figure, you can really see a lot of things are going to lead to hypoxemia here, such as being in high altitude. We have these disorders taking place, intracardiac defects or atriovenous malformations leading to it as well. And again, this means that we have a reduced amount of oxygen within our arterial blood. And this can then lead to tissue hypoxia, which is a reduced oxygenation of the cells and tissues. So you really should differentiate these two terms. Hypoxemia, because it ends with emia, is referring to the amount of oxygen in the blood, whereas hypoxia is referring to the oxygen to the cells and the tissues. So when we are also talking about hypoxemia, it's really because we're having some type of problem with either one or more of the major mechanisms of oxygenation. So first, maybe oxygen delivery to the alveoli is being affected. Remember, that's the air moving into those little air sacs. Or maybe we're having issues with the diffusion process of the oxygen moving from the alveoli into the blood of these capillaries. Or we're having issues with perfusion of the pulmonary system. So signs of this early on will be more like restlessness and anxiety. Late would be cyanosis taking place. And chronic, of course, would be the clubbing that we talked about in the previous slide. And so we can be seeing those ventilation perfusion abnormalities taking place in this figure over here. And this inadequate ventilation of well-perfused areas of the lung is known as a low VQ or a shunt. And that results in wasted perfusion. So you can kind of see how this alveolus is a little bit collapsed over here. So mismatching of this type is going to take place in atelectasis. We'll talk a little bit more about that in a coming slide. It can also be an asthma as a result of bronchoconstriction that would be taking place over here, and also pulmonary edema and pneumonia when the alveoli are filled with fluid. Now, in a high VQ ratio, where again V is going to refer to the ventilation, Q is referring to the perfusion. So when we have this a high ratio, that means that our alveoli are well ventilated, but they're not adequately perfused. So this can lead to wasted ventilation as well, because our oxygen is not efficiently transferred to the blood, and this could be due to poor blood flow. You can see how this is all still blue around in this area. And this can happen in pulmonary embolism because a clot could maybe obstruct blood flow to part of the lung, and this creates a dead space ventilation. It can happen in shock or hypovolemia, where we aren't getting enough blood flow overall. It could happen in emphysema when we lose some of the pulmonary capillaries that can lead to these areas of ventilation but not adequate perfusion. Or it can happen in a pulmonary vascular disease such as pulmonary hypertension or chronic thromboembolic disease that can reduce blood flow to certain areas of the lungs. And when someone has acute respiratory failure, this can take place when we are failing to maintain adequate gas exchange, and that could lead to hypoxemia or hypercapnia or both. And it tends to result from direct injury to the lungs, airways, or the chest wall itself, or indirectly because of a disease or injury that's involving another body system, such as the brain, spinal cord, or the heart. There are different types, like type 1 or type 2. Type 1 is also known as hypoxemic respiratory failure. Type 2 is known as hypercapnic respiratory failure. And in order to diagnose this, we would need blood gas data, chest x-ray or CT scan. We can also use pulse oximetry or pulmonary function test to, again, diagnose this. So here's a question. A patient has bulbous enlargement of the distal segments of the fingers. Which disease is associated with this condition? Do we remember? If you said the answer is A, you are correct. Along with bronchiectasis, pulmonary fibrosis, lung abscesses, and congenital heart disease, in which we are going to see decreased oxygenation taking place. Next, let's talk about some chest wall restriction disorders. It's really anything that is going to compromise our chest wall through deformation, immobilization, and or even obesity. So we see with a normal thoracic cavity, let's say, we are going to have inspiration in which the air comes in and then expiration in which the air moves out. Whereas when we have any type of restriction or damage to the chest wall, we can see flail chest taking place, in which we have instability in a portion of the chest wall. So here is what we see in inspiration, where let's say 3 or more of the adjacent ribs here are either fractured or damaged, and that is going to lead to a segment of this chest wall moving independently from the rest of the thoracic cage. And so this is going to result in what we call paradoxical chest movement. And that is, of course, going to severely impair ventilation and can lead to respiratory failure. So within inhalation or inspiration, we are going to see that the flail segment is going to sink inward instead of expanding. And that's demonstrated by the arrows over here. And in exhalation, we are going to see that flail segment bulge outward instead of contracting. And so this is going to reduce the tidal volume and impair oxygenation, and obviously will increase the work the person has to do in order to breathe. And it's typically associated with pulmonary contusion, which is going to worsen gas exchange due to alveolar hemorrhage and edema. Now let's move into some pleural abnormalities. We've discussed pneumothorax before, in which air is going to enter the pleural cavity. Remember that pressure between the pleural lining and the lung always has to be negative. Otherwise, our elastic properties of the lung are going to cause it to collapse. And air is going to take up space, restricting our lung from being able to expand. And we can have either partial or complete collapse of the affected lung. This could be due to some type of traumatic injury, although I have spoken to some people in which it has been spontaneous. We'll talk about that very soon over here. But we have 2 different types of it due to trauma. We have open pneumothorax, in which during inspiration, our diaphragm is going to contract and pull more air in through the wound. You can kind of see that demonstrated over here and here, and that causes the lung to collapse more. And in expiration, the air is going to leave the cavity. Then we have our tension pneumothorax, in which the air is going to enter and doesn't leave. So that creates more of a positive pressure that then will press on the heart and the wound will act as a one-way valve. And as a result, we'll see that pleural pressure will be above the atmospheric pressure, and that creates an internal tension. And so this can be life-threatening. We can have compression, atelectasis of the unaffected lung. We can also get compression of the vena cava, which of course will then in turn affect the venous return back to the heart. We can also start to see a mediastinal shift. That's kind of demonstrated over here where you see the trachea kind of shifting over, and we would call that a tracheal deviation toward the unaffected side. Now, as I said, doesn't have to be traumatic. It can also be spontaneous, and an air-filled blister on the lung can rupture. And then the atmospheric air is going to enter the cavity because our alveolar pressure is going to be greater than our pleural pressure, and air will accumulate in that pleural space. Here's a good illustration of that pleural space, and the lung will collapse. So we say it's primary because it occurs in the absence of lung disease, and we do see that it occurs more in tall, thin young males and may be associated with smoking, family history, and Marfan syndrome. And then secondary pneumothorax is going to occur as a complication of lung disease. Next, we have pleural effusion, and this is when we are going to have an abnormal accumulation of fluid in our pleural spaces between the lungs and the chest wall. It is going to be classified based on the composition of the fluid and its underlying cause. So you could see we have quite a few different types here. First, we have the transudative or watery type, where we have too much fluid leaving the capillaries due to things like liver failure, nephrotic syndrome, and left-sided heart failure, which is the most common due to increased pulmonary capillary pressure. When we say liver failure, we're also referring to cirrhosis, where we're going to have low oncotic pressure due to hypoalbuminemia. And the fluid in this instance tends to be more of a clear or pale yellow. We don't see a lot of protein or LDH, and also a low white blood cell count, which is going to be different from the exudative type of pleural effusion, where you can see we're referring to the white blood cells and the plasma proteins here, where the cause is typically due to increased capillary permeability due to some type of inflammation, infection, or malignancy. And in that effect, we're going to have the common causes of this be things like pneumonia, tuberculosis, cancer, pulmonary embolism, or autoimmune diseases such as rheumatoid arthritis or lupus. And so this type is going to have a high amount of protein within it, a high LDH, and our high white blood cell count, and may appear more cloudy. If it's a little bloody, it may indicate it's from a malignancy or tuberculosis. And of course, if we have pus within it, that is going to reference our empyema, which typically will also be more of like a thick fluid that is foul smelling. When we have our hemothorax type of pleural effusion, that means we've got blood in the pleural space and is typically due to trauma, although it can be from a ruptured aortic aneurysm or a type of cancer. And we see that greater than 50% of the blood is hematocrit, and will confirm this hemothorax. We also have our chylothorax, and this is when we have reduced drainage by our lymph vessels, which we know as chyle, And the causes of this is typically a thoracic duct injury, and that could be due to trauma, cancer, or some type of surgery. So we see that this fluid is a little bit more milky in appearance and has a high amount of triglycerides. Now let's move into restrictive lung diseases. This is really an umbrella term that is going to refer to a category of respiratory conditions that reduces lung expansion, which leads to decreased lung volumes and impaired gas exchange. And in a bit, we will talk about obstructive lung diseases, some of which you've heard of, like COPD and asthma, which are really more talking about affecting airflow, whereas restrictive lung diseases limit lung compliance, basically our ability of the lung to be able to expand and contract properly. And so our ratio of forced expiratory volume in the first second, which we are calling FEV1, compared to forced vital capacity is close to normal, which is 0.7. And in this category, we can have aspiration, in which we are going to have passage of fluid and solid particles into the lungs. You can see that demonstrated over here, where when we eat food or fluid, it should go back, of course, into the pharynx and then the esophagus. But here we can see that it has moved down into the trachea. Then we have atelectasis, and this is a collapse of lung tissue where it cannot expand. And as you can imagine, we can see here where with restrictive lung disease, it's harder to get that air in. And we can break this down into different types. So we have our compression atelectasis, and this is when we have compression of the lung, of course, and this is common in people with pleural effusion from congestive heart failure or cancer. When we have obstructive, or it's also known as absorption atelectasis, this is when air is absorbed in from the lungs, and you could see this pictured over here in our shallow breathing and showing deep breathing, in which we have a mucus plug in place, and that is creating a complete obstruction of airway, followed by an absorption of the air from the affected alveoli into the space around the lung, and collapse of the area of the lung can take place. This is a high risk post-operatively, especially in patients that suffer from asthma or chronic bronchitis or cystic fibrosis, in which they are going to have excessive mucus production. If they are also dehydrated, it can help thicken those secretions. And this can happen to people that have a foreign body aspiration. So we do see this commonly in children with things like peanuts or small toys, and can also happen to people that have tumors or endobronchial masses that can obstruct these airways. And so as we said, that air is going to move in. We see it goes into the normal side of this alveolus, but it cannot move into this area because it is blocked through that mucus. And we have a closed pore of Kohn. If you remember, that pore of Kohn were the little spaces in between the alveoli. So in this instance, we see that that pore of Kohn has opened and the inspire air has moved in, but we cannot remove that air. It becomes trapped within that area and prevents new air from being able to enter the alveoli. And then we have our surfactant impairment or adhesive atelectasis. This is decreased production or inactivation of surfactant. If you remember from A&P, we talked about how important that surfactant is in breaking up or pulling apart the water molecules so that they don't want to stick together and cause the alveolus to collapse. So they kind of are that first layer within the alveolus to keep it nice and open. We do see this in a lot of babies that are born prematurely because they cannot make surfactant on their own, or it could be due to lung injury. And then we have bronchiectasis, in which it will occur usually in conjunction with other respiratory conditions associated with chronic bronchial inflammation, in which we have obstruction of the airway with mucus plugs, atelectasis, aspiration of a foreign body, infection, cystic fibrosis, tuberculosis, or a congenital weakness of the bronchial wall. It can also be associated with systemic disorders such as IBS or AIDS. There is no known cause, and the primary symptom is going to be a chronic productive cough. And we see that these patients have recurrent lower respiratory tract infections with foul smelling purulent sputum, and hemoptysis and clubbing due to chronic hypoxemia. Bronchiolitis is going to be inflammation of the bronchioles, which are the small airways of our lungs, and we see this most commonly in infants and young children, and it's typically due to a viral infection. You can see the culprit is usually RSV, and it can occur in adults with chronic bronchitis in association with a viral infection or with inhalation of toxic gases. And so when someone has a viral infection, it infects and damages the epithelial cells in the bronchioles. So you could see how they become inflamed and they start to produce more mucus, which causes edema and airway narrowing. And air is going to become trapped, and we can have atelectasis take place, and it will be difficult to exhale. We can also have hypoxemia and respiratory distress develop if it becomes severe. So our signs and symptoms with this will typically be a cough. It could be wet or dry. We may hear some wheezing or crackling, tachypnea, retractions where we're using our accessory muscles to breathe, and nasal flaring, especially within infants. And if it is severe, we can also have cyanosis take place. Then we have pulmonary fibrosis, which is going to be the most common restrictive lung disease. And this is characterized by scarring or fibrosis of our lung tissue, which then leads to reduced lung compliance and impaired gas exchange and progressive into respiratory failure. And it could be idiopathic, which is its most common form, but it has been linked to genetic and environmental factors. And other causes could be autoimmune diseases such as lupus or systemic sclerosis, rheumatoid arthritis. It could be due to certain medications like chemotherapy, or due to chronic inflammation or infections, which all could cause scarring of the tissue. Now let's talk about inhalation disorders. Toxic gases such as smoke, ammonia, hydrogen chloride, sulfur dioxide, chlorine, nitrogen dioxide can all lead to issues with restrictive lung disease and can cause damage to our airway epithelium and promote mucus secretion, inflammation, mucosal edema, and damage to those cilia on those epithelial cells. It can also cause pulmonary edema and surfactant deactivation. And so all of this could progress to ARDS and pneumonia, and can specific toxins could lead to pneumoconiasis, and that is going to cause changes within our lungs due to an inhalation of organic dust particles, which would include silica, asbestos, and coal. It can happen years after exposure with progressive fibrosis of the lung tissue. It can cause chronic inflammation with scarring of our alveolo-capillary membrane, which then leads to the fibrosis. So we will see symptoms of coughing, a chronic sputum production, dyspnea, decreased lung volumes, and hypoxemia. They'll typically do a chest radiograph and also question their occupational history in order to diagnose this. And to treat it, it is palliative and to prevent further exposure to the toxin. We do know that silica is the most abundant mineral in the Earth's crust, and unfortunately breathing that dust can take place by chipping, cutting, drilling, or grinding soil, granite, slate, sandstone, or other natural materials. We can also have a hypersensitivity alveolitis, also known as pneumonitis, and this is an allergic reaction from inhaled particles or fumes. Allergens could be things like grains, bird droppings or feathers, wood, cork dust, animal pellets, coffee beans, fish meal, mushroom compost, and molds. Quite a bit of a list there. And our lymphocytes and inflammatory cells will start to infiltrate our interstitial lung tissue, and they'll release their cytokines, those chemical cell signalers, and the antibodies, which, if it becomes chronic, it can cause pulmonary fibrosis. Then we have pulmonary edema. Now, our normal lung is kept dry by lymphatic drainage and balancing that capillary hydrostatic and oncotic pressure and controlling our capillary permeability. And we also have surfactant there too to repel water and keep it out or at bay so that the alveolus does not collapse. So when some of those things get out of balance or out of sync, then we can start to accumulate excess water within the lungs, and that of course makes it difficult to have proper filling of the air within the alveolus and perfusion take place for into our blood capillaries. Now we can see many things leading to pulmonary edema, but the most common is going to be left-sided heart failure as it's related to valvular dysfunction and coronary artery disease. And so if we look at all of the pathophysiology here, we can see that there's an imbalance in the oncotic or osmotic pressure or hydrostatic pressure. So just to review, the oncotic or osmotic pressure is the movement of fluid from the interstitial fluid back into the capillaries, whereas our hydrostatic pressure forces fluid out of the capillary, and then the osmotic pressure will draw fluid back in. And so following this route over here, if let's say we're having any of these issues here, we start to get increased left atrial pressure, and that then is going to move back into the pulmonary veins, which then is going to increase our pulmonary capillary hydrostatic pressure, and that moves the fluid from the capillaries back into the interstitial space, which moves them basically into those alveoli. With our acute respiratory distress syndrome and inhalation injury, we have injury to the capillary endothelium That then increases the capillary permeability and disrupts surfactant, and we move that fluid and plasma proteins from the capillary to the interstitial space in the alveoli. Fluid starts to accumulate there, and we get pulmonary edema. Then we have due to surgery, tumors, and fibrosis, where we're blocking lymphatic vessels that should be draining that excess fluid, and we then are going to end up with the excess fluid in our interstitial space, which then starts to accumulate in the alveoli, leading to pulmonary edema. Now, for treatment, if the edema is caused by increased hydrostatic pressure from heart failure, like we saw in this route, then therapy is directed toward improving cardiac output with diuretic, vasodilators, and drugs that are going to improve the contraction of the heart muscle. If we have increased permeability from injury, then treatment will be focused on offending the agent and implementing supportive therapy to help maintain adequate ventilation and circulation. And if we have some type of lymphatic blockage going on, then we want to treat the underlying condition. And if necessary, we can apply mechanical ventilation and supplemental oxygen if we are having impairment of ventilation and oxygenation. All right, I mentioned ARDS briefly in, I think it was 2 slides ago, but that stands for Acute Respiratory Distress Syndrome. And this can be a life-threatening condition characterized by severe lung inflammation when we have increased alveolar capillary permeability and non-cardiogenic pulmonary edema, leading to hypoxemic respiratory failure. And we see that it's usually a complication of some type of critical illness, infection, or injury. You can see in this image on the right-hand side where we have bilateral infiltrates on the chest, and we have a buildup in the fluid in the alveoli, so pulmonary edema taking place, and it's preventing the alveoli from being able to fill up with air, and that prevents perfusion of the blood. So we end up with a low ratio of our partial pressure of oxygen to our fraction of inspired oxygen, which refers to the concentration of oxygen in the air that a person breathes. And we tend to see this in people who already have some type of lung disease going on, like we said, and it can trigger an inflammatory response through the capillaries and direct alveolar damage. And it tends to move within these 3 phases. First, we have our exudative phase, which is within 72 hours and can last up to 7 days, where we're getting blockage of gas exchange due to alveolar damage, and we get a hyaline membrane formation where we are going to have some fluid accumulate, and we start to see a severe mismatch of that ventilation perfusion ratio, and hypoxemia is going to start to develop. So as you can imagine, inhalation becomes very difficult. Then we have our proliferative phase, which are days 4 to 21, although it can range from 7 to 21 days, where we're going to start to see our fibroblasts proliferate. And we are trying to repair the lung. We have proteolytic enzymes that are released. So some patients are able to recover, while others are going to progress to the next phase, which is fibrotic phase, or fibrotic phase, which is going to happen either after 21 days or more, or it could begin as early as 14 days. And this is in the severest phase of this type of syndrome, where we are going to start to have a fibrous protein production. Our lung cannot expand anymore due to the persistent lung scarring, and we have irreversible loss of function taking place. So we have damage to our type 2 alveolar cells, which are the ones that produce surfactant, and this then progresses to atelectasis, which then can progress to chronic respiratory failure and pulmonary hypertension. So now let's talk about some of the clinical manifestations that these patients are going to have. They'll have dyspnea and hypoxemia, even though we're giving them supplemental oxygen. They can have hyperventilation and respiratory alkalosis, a decreased tissue perfusion and metabolic acidosis, and organ dysfunction. We have increased work of breathing, so we're using our accessory muscles. We're also seeing that the patient has nasal flaring and intercostal retractions. We see decreased tidal volume and hypoventilation. We can also see hypercapnia and respiratory acidosis and respiratory failure, decreased cardiac output, hypotension, which can also extend to multi-organ failure and even progress to death. And so to treat this, we can do mechanical ventilation in order to protect the lung, and then we can give oxygen therapy, treat the underlying cause. For instance, if it's an infection, we want to give antibiotics. We can also give steroids, which is a little bit controversial, but it may help in the later stages of this syndrome, and diuretics to manage the fluid overload, but we have to avoid hypovolemia. We also want to give supportive care, so make sure we have fluid management, sedation and neuromuscular blockade, and nutritional support. We can also give extracorporeal membrane oxygenation. This is really only used in severe cases when mechanical ventilation is failing. All right, question here. Which of the following is true regarding acute respiratory distress syndrome? If you said the answer is B, you are correct. It can cause severe pulmonary edema because damage is done to the alveolar capillary membrane and causes severe pulmonary edema as a result. Now let's get into a different set of lung diseases known as obstructive lung diseases. These diseases are characterized by airflow limitation due to increased airway resistance, which means we are making exhalation more difficult. So the conditions we're going to talk about here are going to have air trapping taking place. We have hyperinflation and decreased expiratory flow rates. So we'll talk about things like COPD, asthma, bronchiectasis, and cystic fibrosis. And like we said, we are going to have a ratio of forced expiratory volume in the first second, or FEV1, compared to the forced vital capacity become reduced, meaning it's less than 0.7. So harder to get that air out. And like we said, our lungs will tend to be hyperinflated. So we may hear some wheezing and some rales, meaning we get some abnormal rattling sound from the collected fluid within the alveoli. And that is partly because of the narrowing of the airways that is going to become worse with expiration. And so we will use our accessory muscles of expiration. This would include our internal intercostals, our abdominal muscles, our transversus thoracicus, our subcostals, and even our iliocostalis. If you remember our I love spaghetti muscles in our back, this would be the iliocostalis. And we also use the quadratus lumborum and serratus anterior. So as you can imagine, with all of those accessory muscles being called upon, we have this increased workload for breathing. And this, of course, will have dyspnea as a clinical manifestation as well. So let's first start off talking about asthma. This is going to be a chronic inflammation of the airways. You can see it pictured over here where we have a narrowing and an overproduction of mucus. We have a bronchial hyperresponsiveness that takes place, and therefore reversible airflow obstruction. So let's go through the path of an early asthmatic response. When we inhale a antigen, you can see that in the green over here, that is going to bind to our mast cell, which is covered with our IgE, and that binding is going to cause the mast cell to degranulate. So we start releasing histamine, our bradykinins, leukotrienes, prostaglandins, platelet activating factor, and interleukins, which are going to induce an active bronchospasm. So we start to see the bronchi and bronchioles really narrow on in. And then we get edema from increased capillary permeability, which happens from the histamine and other chemicals that are being released. And we get more mucus being secreted from the goblet cells that are found amongst the epithelial cells here. Now we can also see that our antigen presenting cells, our dendritic cells, are also finding these antigens, and they are going to communicate this with our helper T cells over here, and they're going to produce interleukins. You can see this one is IL-4, and you can see IL-5 being produced and released here, and these are going to promote the switching of our B cells. So I'll move back over here, our B cells over here, to favor the IgE production. So they will produce more of our IgE, and our helper T cells that were producing the IL-5 are going to activate our eosinophils. Now, these are going to have specific products produced, such as proteins that can then go and damage our respiratory epithelium and activate our neutrophils that then help activate our inflammatory process, and that leads to airway obstruction. Now, one of the things we can watch out for is pulsus paradoxus. And this is going to be an exaggerated decrease within our systolic blood pressure during inspiration of more than 10 millimeters mercury. So this will serve for us as a clinical sign, especially in cardiac tamponade, but it can occur in conditions causing increased intrathoracic pressure or airway obstruction as well. Now, in severe life-threatening asthma, we will have status asthmaticus. And this is when we have asthma taking place in which we have severe bronchospasms that doesn't really respond to standard treatments like bronchodilators and corticosteroids, and it can lead to progressive respiratory distress, severe airway obstruction, and potentially respiratory failure. So we want to make sure to give immediate airway and oxygen support, our bronchodilators and corticosteroids in order to reduce the inflammation and prevent a relapse. And we can give magnesium sulfate for severe cases to help relax the bronchial smooth muscles. We can also give epinephrine if it's severe or anaphylaxis is suspected, and mechanical ventilation if we do progress to respiratory failure. Next, we have chronic obstructive pulmonary disease, or COPD. This is characterized by persistent airflow limitation and is a progressive and irreversible lung disease where we are going to get chronic inflammation, mucus production, and alveolar destruction. It's going to include two main types of diseases, which is chronic bronchitis and emphysema, and it's typically caused by smoking. Or long-term exposure to lung irritants, such as those occupational dusts we talked about, and chemicals, air pollution, and really any other factor that affects lung growth during gestation and childhood. And this is the most chronic lung disease in the world. You could see that air goes in, and here you can see that it becomes blocked by the mucus and cannot move back out. So let's go ahead and talk about chronic bronchitis first. This is when we have a hyper secretion of mucus and chronic productive cough that is lasting at least 3 months of the year and for at least 2 consecutive years. And inflammation and thickening of the mucous membrane is pictured over here, with the pus and mucus leading to obstruction, and that leads to that productive cough that we mentioned. To treat this, we can use bronchodilators, expectorants, and chest physical therapy. And then the other disease we're going to talk about for COPD is emphysema. This is an abnormal permanent enlargement of the gas exchange airways, and it's accompanied by destruction of the alveolar walls without obvious fibrosis. So you can see in this image how we have these nice separate air sacs here, but in emphysema those walls kind of break down and we have one large alveolus, and this of course is going to decrease the surface area, and so we're not having as much gas exchange taking place. So as a part of the pathophysiology, we get elastin breakdown, and this could be due to smoking or an alpha-1 antitrypsin deficiency. And due to that breakdown in elastin, we are not going to have that elastic recoil. So we get hyperinflammation and air trapping taking place, and in these patients we'll see a barrel-shaped chest. We also will have increased work in breathing, so dyspnea with pursed-lipped breathing that could be clinically demonstrated on these patients. And that pursed-lip breathing is really to prevent alveolar collapse. We'll see that these patients are also very thin in appearance and have muscle wasting because it is very laborious for them to breathe, and they tend to have pink skin. So emphysema is known as the pink puffer because of that compensation in hyperventilating. So here's a question: which of the following is true regarding the pathophysiology of asthma? And if you said the correct answer is inflammation results in hyperresponsiveness, you are correct. We know that asthma is going to be caused by increased bronchial smooth muscle spasm and increased vascular permeability, and IgE is the major factor for this. There's going to be increased capillary permeability, and our inflammatory mediators cause vasodilation, increased capillary permeability, mucosal edema, bronchial smooth muscle contraction, and mucus secretion from our mucosal goblet cells, with narrowing of those airways and obstruction to airflow. Now let's move into respiratory tract infections. First up is acute bronchitis, and this is a self-limiting inflammation of the bronchi, and it's typically caused by a viral infection. We're going to see that these patients will have coughing, mucus production, and irritation to their airways, but it lasts less than 3 weeks. So it is possible to have this caused by a bacterial infection, but it's pretty rare. It's about 10% of cases, whereas 90% of the cases is due to a virus. And there are some non-infectious causes as well, such as irritants like smoke and pollution, or maybe due to allergens like dust, mold, or pollen. So as far as the pathophysiology, because of the viral infection, we get inflammation from the bronchial lining, and the increased mucus production is causing the cough and sputum production. When we have bronchial hyperactivity, then that will cause them to have wheezing and a mild airway obstruction. And it tends to resolve, like we said, in about a week or max 3 weeks. And to diagnose this, we really look at the symptoms and any exam findings. So when we give a physical exam, we are trying to see if they're having any wheezing taking place, and trying to make sure that we can rule out pneumonia. So if we are suspecting pneumonia, then we want to do a chest x-ray, and things that would kind of make us suspect that they have pneumonia is if they have a high fever, tachypnea, or tachycardia, and if we have like a dullness to percussion or echophony taking place. And to treat it, we can use some cough suppressants, expectorants to thin out that mucus, NSAIDs if they have a fever or have chest discomfort, and we want to recommend that the patient stays hydrated and maybe uses an air humidifier. We can also give bronchodilators if there is wheezing and it is persisting, and give antibiotics if we think this is caused by a bacterial infection. Now let's talk about pneumonia in detail. Now this is an infection of the alveoli and the lung tissue that's going to lead to inflammation, fluid accumulation, and impaired gas exchange. It could be caused by bacteria, viruses, fungi, or aspiration, or other less common microbes like protozoa and parasites. And it could be classified based on the setting of the infection. So we have our community acquired, or CAP. Usual suspect for that is going to be our Streptococcus pneumoniae and the influenza virus. We have our healthcare acquired and ventilator associated. And this one tends to develop at or greater than 48 hours of intubation. And so with any of these, we are going to have pathogens that reach the alveoli, and then we get inflammation and our immune response taking place, where our alveoli will start filling with fluid and our neutrophils. And with that fluid being present there and inflammation, that will then start to impair gas exchange, which can lead to hypoxia, dyspnea, and our VQ mismatch. And you could see a little bit of that pathophysiology in this figure from your book, where we talk about an aspiration of our Streptococcus pneumoniae and it leading to an inflammatory response and our immune cells kind of infiltrating the area and hopefully recovering from that infection. Next, let's talk about tuberculosis. This is a bacterial infection caused by Mycobacterium tuberculosis that will primarily affect the lungs, but it can also involve other organs as well. And it's a chronic disease that can either be latent or active. And this leads is the leading cause of death from a curable infectious disease in the world. Now, when somebody is, let's say, categorized as a latent tuberculosis infection, they typically are asymptomatic. They kind of carry the bacteria, but doesn't really know that they have an active infection. They, at this point, are non-infectious, so they can't spread it to other people, but it is possible to have a progression and have that tuberculosis fully active if our immune system weakens, and that can then, progress and become a active tuberculosis disease. So when the disease is active, we are going to start to see symptoms as the bacteria multiply, and you become infectious, meaning you could spread it to other people through airborne droplets, meaning you're coughing or sneezing, and it could go and infect others. And while it's active, that's when it could go and affect other organs. So it could go to the kidneys, the spine, the brain, which is what we call extrapulmonary tuberculosis. So how does this pathophysiology take place? So we know that the bacteria has to enter our lungs. You can see that pictured over here. And then we have an immune response to it. Our bacteria can evade complete clearance, forming things called granulomas in our lungs. They're also called gone focus. And as a part of that immune response, we are going to form tubercles and caseous necrosis. So when Mycobacterium tuberculosis enters the lungs, our immune system is going to attempt to contain that infection. So our macrophages try to engulf and kill the bacteria, but they aren't able to get rid of all of them. And so we form a granuloma. And this is basically a collection of the immune cells, which would include our macrophages, our T cells, and our fibroblasts. And this granuloma is a protective mechanism so that we can isolate the bacteria. We'll have a central core of it, of macrophages that have been infected with the tuberculosis bacteria, and some of those will turn into epithelioid cells, which are specialized to trap bacteria. Then on the outer edge of that granuloma, we will see more of our T cells and the fibroblasts. And sometimes the bacteria inside the granuloma can continue to replicate and lead into a caseous necrosis. Remember, this was tissue death where we're going to see it become soft and a cheese-like consistency. And that's what that word caseous really refers to, which in Latin means cheese. And this is resulting from that chronic inflammation that is characterized by the presence of dead tissue and the bacteria. Now let's talk about that tuberculin skin test. Some of you have had this test already. This is also known as the Manteau test, and it's used to really see if somebody was exposed to Mycobacterium tuberculosis and has developed a latent form of the infection. And it's really based on an immune response to a purified protein derivative, which is a component of the tuberculosis bacterium. So we can do a small injection. This is usually in the area of the wrist or forearm or even the hand, where we are injecting the tuberculin antigen just underneath the skin. and looking to see if we're going to get a immune response. So if someone has been exposed to TB, then their immune system will recognize that antigen and the T cells will migrate to that site and cause a delayed type of hypersensitivity reaction. So almost like a raised bump that's red, and sometimes it's a little bit itchy too. And we measure that about 48 to 72 hours after that test. So ideally, you don't want to be positive for that. If you've never been infected with TB, then you are going to have no raised bump or a very small reaction, meaning it's going to be smaller than 5 millimeters, and you would consider your test result as negative. Now let's talk about lung abscess formation and cavitation. Lung abscesses is a localized collection of pus within lung tissue caused by microbial infection that can lead to tissue destruction and necrosis. Now typically this is going to happen from aspiration pneumonia, bacterial infections, or complications of conditions such as bronchial obstruction or septic emboli. And progression of the lung abscess can involve necrosis and cavitation. So let's start with how that abscess is going to form. It begins with whatever the infectious agent is. So usually it'll be bacteria like S. aureus, or any anaerobes like Fusobacterium or bacteroids, for example. And they start to invade the lung tissue, the parenchyma, and the body responds by sending neutrophils, macrophages, and inflammatory mediators to the infection site. And so you can see within stage 1 here, we're having that inflammatory infiltration of the lung tissue, meaning all of our immune cells are heading over to that area. And this then is going to lead to pus accumulation, where our neutrophils are releasing enzymes to destroy the bacteria, but these enzymes also cause collateral tissue damage. And then we can start to get a fibrous encapsulation. You can kind of see that encapsulation within this region over here. And the fibroblasts may attempt to wall off this infection, and it forms a thick capsule. This then can progress to necrosis and liquefaction, and the lung tissue will contain this fluid-filled cavity, but eventually necrosis will ensue within this area of the lung tissue because of the severe inflammation, bacterial toxins, or ischemia taking place. So this means that because we have the liquid within here, the enzymes are going to start to break down that lung tissue into thick purulent material, and factors that are going to contribute to this are hypoxia, enzymatic degradation, and bacterial virulence factors, depending of course on what bacteria has infected that region. And so that necrotic area can become really large and break into the airway, and we get necrotic debris and pus, and that can be expelled, forming an air-filled cavity, which you can see much better in this image over here. So this is what we call cavitation, and like we said, it's that air-filled space, and it's due to that necrotic tissue breakdown and evacuation. So these air fluid levels could be seen on imaging, such as a chest x-ray or CT scan, and we see that it is a thick wall around that cavity, and we may see some drainage into bronchi, and that really is that abscess draining. We may have some necrotic material there that can be coughed up as what we call fetid sputum. And we, of course, can see these cavitary lung lesions in conditions like tuberculosis, fungal infections, septic emboli, and malignancies. All right, let's move into pulmonary embolism. This is going to be a life-threatening condition that's caused by a blockage in the pulmonary arteries of our lungs, and it's typically due to a blood clot or a thrombus. But you can see listed here we have some other reasons for it, such as a tissue fragment, lipids, foreign body, air bubble, or amniotic fluid, and these can disrupt blood flow to the lungs, which then impairs gas exchange and can lead to hypoxia and potentially cardiovascular collapse. Now you could see that typically a pulmonary embolus, like we said, is the most common reason for this taking place, and it can arise from the deep veins within the lower legs. And so we see it in people that have deep vein thrombosis. And if you remember, we had that Virchow triad, which is going to have that thrombus form. It dislodges, which is now called an embolus. It then goes to the pulmonary arteries and occludes that pulmonary circulation and can lead to a slew of these clinical manifestations taking place. And next we have pulmonary artery hypertension. And this is when we have high blood pressure in your pulmonary arteries that is going to cause your arteries to narrow. So as a result, your heart is working harder to pump oxygen poor blood into your lungs. And so we can see that that mean pulmonary artery pressure is 5 to 10 millimeters mercury above normal or above 25 millimeters mercury. And it's caused by heritable defects, drugs, veno-occlusive disease, lung or heart disease, systemic disorders, and chronic pulmonary embolism. But we do know that left-sided heart failure is going to lead to this pulmonary artery hypertension. So anything that is related to that, such as an aortic valve disease, left ventricular hypertrophy, or mitral valve disease, COPD, intestinal lung disease, obstructive sleep apnea, or pulmonary embolism that we just talked about. So now let's talk about cor pulmonale, and this refers to right ventricular enlargement, which you can see pictured over here. And this is due to really chronic pulmonary hypertension, which is typically caused by lung disease or pulmonary vascular disorders, and it leads to the right side of the heart being strained and reduces its cardiac output, and therefore is going to lead to systemic congestion. And the way that this really begins is that a lung disease or hypoxia is going to trigger pulmonary vasoconstriction, and this is really to divert the blood to better oxygenated areas, and over time this leads to pulmonary hypertension. So having this high pressure in the pulmonary arteries, and like we said, the right ventricle has to work harder then to pump the blood into the lungs, and this then leads to right ventricular hypertrophy, and eventually this right ventricle is going to weaken, and it leads to that right sided heart failure. So we see that these patients begin with having exertional dyspnea, fatigue, weakness, and tachycardia, and as it advances, then we start to see things like peripheral edema, because that blood is going to start moving back systemically into the veins, and so we get things like swelling in the legs and the ankles, and that jugular venous distension, ascites, where we get a fluid buildup in the abdomen that causes swelling, hepatomegaly, which causes the liver, or is the liver being enlarged. We can also get cyanosis and syncope, where the patient can faint due to reduced cardiac output and hypoxia. All right, now let's move into some malignancies of respiratory tract. So first is laryngeal cancer. This is less than 1% of all cancers within the US, and we do see that it is more common in men. The primary risk factor is smoking. And then we do have a couple of different forms. Carcinoma of the true vocal cords is the most common type, and this is also called glottic cancer, and it is going to involve our true vocal cords, and typically we are going to see early symptoms of hoarseness and voice changes. Another type is the supraglottic cancer, and this happens in about 35% of this type of laryngeal cancer, and it'll involve the area above the vocal cords, which would include the epiglottis, which we could see pictured over here, or the false vocal cords. So that is going to be the upper cords over here, more of the pink color in here. And in this type, we will see symptoms a little bit late, having difficulty swallowing, a sore throat, or maybe even some ear pain. Then we have subglottic, which is the rarest form. It happens in 5% of laryngeal cancers, where we're going to have the cancer involved in the area below the vocal cords. This often is diagnosed late because the symptoms are really subtle. Luckily, distant metastasis is rare, and through treatment with combined chemotherapy and irradiation or surgical resection, it can result in cure in selected cases. We can also have swallowing and speech therapy after treatment to help improve recovery. Now let's talk about lung cancer, which is the leading cause of cancer-related deaths worldwide, and it's arising from uncontrolled cell growth in the lung tissue. Nearly 80% is caused by cigarette smoking, and smokers with COPD have an even greater risk. But we can have non-smokers develop this as well due to environmental and genetic factors. So let's talk about the different types. We have non-small cell cancer, and this is about 85% of cases, of all lung cancer cases, I should say. And we include in that our squamous cell carcinoma, which you could see here at the letter A, and this is associated with smoking. Typically, we find it more central near the bronchi, and we have a strong link to paraneoplastic syndromes such as hypercalcemia due to a parathyroid hormone production. We also have our adenocarcinoma, which you could see pictured in B here, and this is showing a tumor that is a prominent black pigmentation, suggesting that they have evolved in a nephrotic scar. And this is the most common type of non-small cell cancer. It happens in about 40% of cases, and especially within non-smokers. And so we've seen this linked to some mutations. Then we have large cell carcinoma, which is the rarest of all the types, and it's poorly differentiated but is aggressive, and we tend to find it in the periphery of the lung as far as location. And then we have small cell lung carcinoma, which you could see pictured here at the C, and this is from neuroendocrine tissue, which is highly aggressive and it is rapidly growing. It's almost exclusively in smokers, and we find it central in location near the large bronchi. We also see in this type that it does metastasize early and can travel to areas like the brain, liver, bones, and adrenal glands. Now, some lung cancers produce hormones or immune responses that can lead to systemic symptoms, and this is one of them. So we can have it lead to Cushing's syndrome or SIAD, and in order to treat this, we would do chemotherapy and radiation, and may even do prophylactic cranial irradiation to prevent the cancer from traveling to the brain. And if we were talking about treatments for non-small cell lung cancer, then we would want to maybe do surgery like a lobectomy or pneumoectomy, so that we can get rid of all the cancer there, and we can do adjuvant chemotherapy, and if necessary, chemoradiation or targeted therapy or immunotherapy. Now for our last question here, a patient has right ventricular enlargement secondary to pulmonary hypertension. Which of the following would be the most likely diagnosis? If you said the correct answer is A, you would be correct.